So I just wanted, one of the things is the vector that you talked about over the course of Dr. Flanigan and Dr. Muenzer. Can you kind of go into what's the limiting to the vector production? I know it's kind of new, but I just kind of want to, over time, do you see it, what it really is going to increase the ability to produce it on a mass scale?
Creating a vector is not as simple, for example, as making a medicinal chemistry product where scalability is quite clear and predictable. You're making a biologic product. Every production run, you infect cells with plasmids that contain your genes that you want to package, plus the genes that help it to package into the virus. The efficiency of this varies. The efficiency of it varies as you scale up in size. I can tell you that multiple companies, both companies who have licensed some of the products you've heard about, are developing capacity to try to expand that. There's multiple groups working on changing the sizes of the bioreactors and the methodology for that bioreactor to do it. So if you grow cells in stacks of plates where the cells are adherent and we feed the cells with the plasmids we need and then pull it away, we can only make so much, as opposed to putting it into big 500-liter bioreactors that are needed for really very large scale. So it's not a simple linear process of scalability. It has to sort of be redesigned at each step. Clearly, production is a bottleneck for trials. And at our institution, for example, at Nationwide Children's, we have what's called a GMP production facility. That's actually something we should just mention. That's a good manufacturing practice facility. It meets the requirements for the FDA to move on to clinical trials. We can make loads of stuff, and people do at every institution, viral vectors that we use for research and so on, not pure enough for giving to people. So there's a bottleneck at our institution where we're expanding our GMP facility, doubling in size so we can run simultaneous campaigns. This is true at places like North Carolina and elsewhere where a variety of strategies have been used to scale up. Big effort right now. I would predict, there are companies coming on board who are just going to be contract houses for scalability of these things as well. So the GMP side is lagging behind, but everybody recognizes that that's the bottleneck right now for moving trials forward. That's my opinion, at least.
I absolutely agree with that. I think it is the bottleneck. There are companies who are going to gear up to this. The next couple of years it's going to be a constraint, but hopefully in the future it's not going to be. But still, this is not an inexpensive process. We're talking about $1 or $1.5 million to make enough vector for the initial clinical trials for any given clinical disorder. And so that's one of the challenges. It's not inexpensive, and so it's hard really to do it out of an academic base. You really need some sort of collaboration, in terms of funding to do this. And one of the other challenges for gene therapy I'll just raise is that we can do the clinical trials, but what I call commercialization is still a significant challenge. How do you actually get this drug commercialized? Because, one, there's a lot of regulatory hurdles, there's a lot of paperwork required for that registration around the world. And if you're talking about a technique that's one and done, that is, you do it once in theory, you never do it again. That's still a long ways away. It's still a significant challenge. So it's not like IVERT where, every week you pay for that drug, and that's how it basically justifies companies developing more. So it's still a challenge, but I think we need to show the proof of concept. We need to show that it's going to work in patients. We know in animals it does, but that's a long way for showing in patients. And I think, until we get some really good clinical data showing these patients are benefiting from this, then I think that, that once we show that, that will spur more development. We'll encourage companies to come on board and develop this. And there's going to be companies who are just going to make the vector. They have no invested interest in anything else. That's their commercial entity. Unfortunately, that's going to raise the cost of the vectors, though, as we do it go forward.
Hello. I had a question about intrathecal enzyme replacement. Dr. Dickson was talking about it a lot. Are you looking at patients post-bone marrow transplant or not, or does it make a difference?
So our study is currently looking at subjects who either have not had a bone marrow transplant or did not have a engraftment in their bone marrow transplant. But currently we are only evaluating a 5-year extension study of the subjects who have been treated so far. The Orchard study, the Paul Orchard study in Minnesota, is using transplant concurrently with intrathecal enzyme replacement therapy, so looking at very young subjects who are getting transplanted. Just for the first year, and they get, and intrathecal is only for the first year there in that study.
Gotcha. I had another quick question. I think Dr. Muenzer hit on spinal decompression a little bit. Our daughter recently had spinal decompression surgery, and we're wondering, is there risk of reoccurrence of spinal compression?
I think the question is absolute. There is a risk of recurrence because with surgery, you basically try to open up the dura so it's not basically squeezing the spinal cord. You're not treating the primary event, which is that dura getting thicker. You may not have any problems in the area decompressed, but potentially you could have areas down lower now become tight. So it still needs to be monitored. As you appreciate it, it's a challenging procedure. I presume your daughter did well, but this is a procedure or not so well. You want to just comment on how that, for other people, what that was like?
Yes. Well, we had an incident during the surgery where her neck shifted. The theory was that the doctor believes that some of her ligaments failed while she was on the operating table, and material shifted and bruised her spinal cord. So we took her out of the surgery, and we had a emergency surgery the next day that was far, far more complicated. It was successful, but she ended up having to be in a halo where that wasn't predicted before. She had a trach placed so they could do the surgery, not from the back. Actually, they went through her mouth to decompress the front side of the spinal cord. So it was much, much more complicated, much longer recovery time, but it was successful, and she is doing better now, but it's been a year and a half.
There's absolutely no question that one needs something to prevent this from occurring from the beginning, and I think that's where some of Dr. Dickson's data is really encouraging, that we can potentially try to prevent this, because once you have this really thick dura, I think it's very challenging to really shrink it dramatically. But I think we can prevent it from occurring, and so that'll be the challenge in the future, and that may be, even as you know, for transplanted patients, it still can be an issue. And so that may be that, at some point there need to be clinical studies to try to do that. But, the challenge is how to deliver it consistently, the enzyme into the spinal fluid safely, and you've heard there's lots of potential options in the future, and we'll just have to see what. Companies are not so much looking at this dura thickening as an issue, they're looking at cognitive impairment, but whatever works for cognitive impairment should potentially work for dura thickening and preventing problems.
Great.
But prevention is really the name of the game, and that's one of the challenges. When do you start a therapy that currently is still invasive? It's currently not proven.
Thank you.
Okay, I'm a little shorter. 2 questions. The first being, there have been instances of the FDA allowing for expanded access of, medications that are in trial. So patients who would benefit from it, even though it is still in trial, might have access to it. Is that something that might be an option for some of the gene therapy or enzyme replacement that's going on now?
Okay, in terms of expanded access, so the first step is to get the company to agree to share it. So that is often the first where it ends, and they have many reasons for that. I mean, a lot of it's not necessarily that they're evil people. It's really more. There are really legitimate reasons not to share these things in this way, and they have to balance their compassion with the program. And so, so my contribution to this question, Dr. Flanigan has a lot more to say on gene therapy, but the big thing is just it varies from drug to drug and from patient to patient, because the situation may be very different. In one company may take it on a case-by-case basis. One company may just say blanket no, and there's just their policy, and there's really not much us clinicians can do about it if it's still an experimental therapy.
I'll just add to that, one of the requirements for FDA approval of expanded access requests is that it doesn't result in detriment to a definitive trial, to trials that do it. So particularly for gene therapies where there's a limited amount of vector that's produced, a limited number of patients that can produce with a given lot, to petition for expanded access in a way that would remove treatment of patients from a trial when there's no it's essentially unlikely to be approved by the FDA. And, the situation's somewhat different if all children with, for example, Sanfilippo disease, 3A or 3B, are at different stages of disease, but there's seldom an evidence that immediate treatment with this vector will be life-saving and should be withdrawn from someone else in a trial. The FDA doesn't make those kind of approvals under those programs.
So along with that, where should we be focusing our efforts when we're fundraising, or just in general? Should it be on trying to raise money specifically for research? Should we be advocating somewhere along the line with the FDA, the pharmaceutical companies, somewhere like that? What is the best way for us to get more kids access to some of these therapies that are coming along?
I think the challenge is what therapies are coming along, and as in any clinical trials, there's really only a limited number of subjects studied, and those subjects are studied within the context of the clinical trial. And so especially the safety trials, normally there's only a certain number selected anyway. I think one of the challenges is, as we're talking now, it's that as we develop new therapies, not everybody, quote, is an ideal candidate, what people consider an ideal candidate, because what we want is to develop a therapy that we can prove to the FDA is beneficial. It doesn't mean that everybody won't be treated. A good example was the intrathecal trial that I'm involved in. We excluded patients who had increased intracranial pressure because of the potential safety factor that may make it more dangerous to use that drug. We had no knowledge that would be the case, but that was just an exclusion because the goal was to try to get the drug approved. The goal, unfortunately, is not to treat everybody in these trials, and that's one of the challenges. Clinical trials are not designed to treat everybody. And I know from a parent's perspective, it's hard for me to hear that, but that's one of the realities. And so the goal is to try to get the drug available to everybody by approving it, and then it can be available because of the cost. For example, the cost for these trials are incredible. If there was more vector, it would be a different issue if there was vector for 100 patients. It would be a very different issue if that was so readily available. For example, we're not limited in terms of intrathecal enzyme. We're not limited by ironic IT. That the company Shire has made enough of that for more than adequate treatment. But there's a point where these trials are expensive. They can do so much, and then they have to try to get approval. Because if they don't get approval, they can't continue these very expensive trials. So I think the challenge you have is a multifactorial question. Where to raise money is really, it's what your interests are. There's all sorts of things happening. There's clearly need. Resources are clearly a limitation. Vector development is a good example for different trials. Vector is going to limit, but it's also the clinical trials. Kevin doesn't work for free. I don't work for free doing these clinical trials. We're involved in these, but we can't work for free. We got to become safe. Our institutions won't let us work for free. So I think it's a tough question, but I think one needs to sort of figure out what your interests are and support that. There's no good answer to your question, unfortunately.
Yeah, I was going to say that we could hold an entire 2-day meeting on your question and still not come up with not agree on an answer to that.
I had a question back to gene therapy. You had touched a little bit on the complications of getting it from, just to human trials in the first place and then from human to commercial. And one of the things that I was concerned about being a difficulty going into commercially and how long that would take is obviously with enzyme replacement therapy, if we look, 50 years down the road and oh no, all the, everybody with enzyme replacement therapy is getting cancer or something, I don't know, a long-term effect that we didn't predict and didn't see until people had been on it for a significant amount of time, we can stop giving them enzyme replacement therapy if we discover there's something detrimental and they shouldn't be getting it. With gene therapy, it's not quite that simple. Like you said, we're hoping for a one and done. We can't just go, oh no, because I think I remember at one point in time, a long time ago when I first started hearing about gene therapy from Mark Sands. He said at one point in time with the vector that he was using all the time, suddenly all his mice started getting liver tumors. So they had to go back through and look at things again. So knowing that and knowing that you can't just go back and undo the gene replacement therapy, you can't just stop that treatment, it's already done. Do you predict that the FDA will want to take a longer period of time on the trial itself, watching the patients for long-term consequences before they put it out to the open market?
I can address that in the context of our current trial. So the FDA understands the severity of this disease, the progression of this disease, of Sanfilippo disease. They understand the risk that parents are willing to tolerate for this. They do ask us for long-term efficacy and follow-up. They ask us for 15 years of follow-up exactly for the reasons you say. We will be thrilled to have 15 years of follow-up in every patient that we treat because we know we know what the course of the disease is. So the FDA, I can tell you that the protocols that we've outlined, again, our trial that I defined for you is defined as a safety trial first with secondary outcome measures that we're not at a point to really judge the efficacy of this. I'm quite convinced that if we show efficacy measures, they'll be looked upon favorably by the FDA. The FDA, I believe, really, particularly over the past several years, is my impression related to a lot of parent advocacy, understands really the urgency that the patient, the family communities feel about these rare diseases and the risk tolerance that people are willing to accept. So I don't think it's, I think if we show efficacy for any of the things we've talked about over the scale of time we've talked about doing it, they will lead to relatively rapid approvals of these drugs.
Attorney Kevin commented, the FDA is changing. They're getting better. They still have a way to go, and some of the people in the audience who have advocated for the FDA have been there, realize there are changing, but they still have people within them who are reluctant to have individuals take risks. They're starting to understand the severity of the MPS disorders and what the consequences they have.
Because I know that you guys appreciate that really liver tumors are the least of our concerns right now.
No, but what you have to, like any therapy, has risk.
Yeah.
There's benefit and there's risk, and that's what we got to define, and so that will take time. And again, I think any Sanfilippo parent would take a potential tumor risk in 40 years from now for basically stabilization of the brain disease. That's a no-brainer, right?
Yeah.
But again, that's just part of, we may find things in the future, oh yeah, that really wasn't the best thing to do, but that's all there is now. As you appreciate, this is a terrible disorders we deal with, and we have really no significant intervention from a lot of the Sanfilippo patients, have not had, and so that's really the challenge. So it's really that risk versus benefit, looking at that, the climate is changing, it's still there still have to be safety. I mean, as Kevin said, this Sanfilippo trial here at Nationwide is really a safety trial. The goal is to make sure we're not causing anything really bad to happen in the first couple of years. The evidence from the literature and from all the other AAV trials, there isn't anything going to happen, but we never know in any given disorder, and so that's really the goal. Any sort of measure they get in terms of efficacy is basically frosting. That's just extra, and yes, we'd like to see that, and companies really want to see that, but we really got to be careful in terms of, they have to be careful when they sort of announce stuff and say things. You really have to have good data. You can't speculate. As you guys, you want therapy. You hear any inkling, that's great, because in the past there's been no inkling of promise, right? It's challenging developing drugs and developing therapies, but it's happening. It is happening.
Thanks, John.
So I'm very excited about all the treatments and opportunities coming around for Sanfilippo. We've really needed that for a long time. My child has Morquio, and I am curious about, will that translate, with gene therapy, does that maybe perhaps translate to that, helping out with Morquio? And then my second question is, there's been a lot of work in cancer with T cells attacking the cancer, and why couldn't you use the immune system to attack the sulfates in the body in a similar way? And I'm just curious about your response on that.
Let me just start. I think the latter question is the easier one. The immune therapy is going after cells, and they're recognizing cells. There's really no way to take an antibody. We wouldn't want to take an antibody that reacts and tries to get rid of glycosaminoglycan glycan. They need to be there. So the immune therapy concept is great for cancers where you have a malignancy, that a cell that's sort of abnormal, and you can try to wipe that cell out. So I think that's not a potential therapy for the MPSs. You know, the first question in terms of Morchio, things that work for one of the MPSs in terms of systemic delivery potentially could work for the other MPSs. So what works for MPS 1 or 2 or for 6 could potentially apply to Morchio. So that's yes. There may not be anybody working on that, and there's clearly, I'm not aware of gene therapy for Morchio, even though there probably is somebody doing preclinical. I just, you know, not aware of that right off my hand. But for example, you know, what happened in MPS 7, a very rare disorder, basically that was, only trial was done because we knew if you make the enzyme in the right way, you're going to get benefit. And that's a translation that they could have never started with the MPS 7 patients. There wasn't enough of them to do it. But the fact they had the experience with 1 and 2 and 6, it was in some ways a no-brainer that was going to work. If you make the enzyme, qualify it in the right form, and deliver it as we had, you're going to get benefit. And you do it before there's significant disease. Absolutely.
The only thing I might add to that is I think the other thing is from a regulatory point of view, both at the FDA and at individual institutional review boards, ethic boards at hospitals, the more patients who've been treated with AAV without significant, in more diseases, there is a general growing, a broader acceptance of the safety profile. So every trial is, I think, beneficial till when someone gets, the person who does the preclinical work for Morchio will have a much, I think, a much more well-defined pathway to clinical therapy through the regulatory, through the pre-IND interactions and through clinical trial design and ethical interactions.
One of the challenges with Morchio and certainly Meritolamia and SLY is really the number of patients. You have to realize that here in this audience, these disorders are common. These are incredibly rare disorders. Pharmaceutical companies, you know, 15 years ago when they heard there was only, say, 500 MPS, you know, 2 patients or 500 Sanfilippo A's and only maybe 100 Morchio, it's like they walk out the door. It's just, so that's one of the challenges is for companies to realize, can they do things in the very rare disorders? I mean, there's rare disorders, and then there's what I call ultra-orphan disorders, which are the MPSs, which make the challenges. It's still amazing to me that there's as many companies in this field as there is. It's just phenomenal. I mean, I would not have predicted this 10 years ago at all.
On that point, 25 years ago, as you remember, not even that long, you said 10 years, there were 0 companies in our space, but now you mentioned earlier there's up to 20. All of them interested in MPS products to help our lives better based on the science provided by these wonderful people here. But the question that came up last night often was many of the new companies are involved in gene therapy, and many of the vectors you mentioned will be the same vector, AAV9 or 10, something along that line. So the question is, although we all hope and pray that the trial is successful and the product works, perhaps they won't. So if a child family signs up for their gene therapy trial and finds that the vector does not work, are they excluded from future therapies in the gene therapy of any type, or is it just with that same vector, or is there any repercussions whatsoever?
Well, I'll say there's a short answer and a long answer to your question. The short answer is in the immediate term, in designing a trial. For example, if we were doing in our AAV9 trial, if someone has been in a trial with another vector, and it's RH74, we would be reluctant to include that patient. We're not in that situation now where there's multiple trials that exist, but we'd be reluctant to include a patient in our trial because of the fact that an adverse event from a trial 2.5 years ago, let's say, could occur that would be attributed to the product that we're developing. So it does complicate things to have multiple therapies, to take part in multiple trials in a very similar pathway, just as it might currently, in our understanding, enzyme replacement therapies, where we haven't seen data yet on antibody responses to transgene to the recombinant protein, can complicate the idea of how we might go into a trial, a response that might occur to a safety response that might occur to an AAV9 gene therapy trial. So that's the short answer, or the pessimistic answer. The optimistic answer is once these are approved and outside of the trial stage, where we're really trying to pull out what responses, what are detrimental responses to our experimental therapies, when they're approved, we can rapidly see an idea where a patient, for example, who had been on a trial of AAV9 therapy, if a product comes out that's an AAV10-based therapy, they have antibodies to AAV9 but no antibodies to AAV10, there is not a reason we can't consider treating that patient if that drug became, available. Similarly, once if AAV9 were to be approved, there will clearly have to be an idea of how do we address patients who've been through enzyme replacement therapies, or how do we, whether that's as an adjunct therapy or whether that's as a subsequent therapy. So there's work to be done, but you know, I think we readily foresee a day where it's possible to retreat patients, but it's just the idea of going from one subsequent trial to the next is really not conceivable for how these trials are designed. I think that's one of the things that Dr. Muenzer mentioned before. We view these in the patient community and even among physicians, and we think we're treating a patient, we're doing a treatment. What we're actually doing is trying to do a well-controlled experiment to understand whether what we're doing is harmful to the patient or not. And we have to really make those decisions about enrollment based upon that, kind of give us that cleanest answer. The worst thing we could do is kill a promising development program by enrolling someone who has something else that confuses it. We don't want to attribute something bad to our AAV9 vector or any other therapy that's really due to, because we picked the wrong people for the trial based on other medical conditions or other past involvements in trials. So that's a long answer to it. So long term, I'm optimistic. In the idea of immediate jumping from trial to trial, it's not really practical, at least from my view as a clinical trialist.
I have a question. Hi, my name is Amy Cherstrom. I have 2 boys with MPS II. I wanted to ask, there's a little background and I swear a question attached to this. So one of the things when we were looking at clinical trials for our sons with Hunter syndrome, we were able to do some cognitive testing ahead of, you know, looking to enroll in the trial and qualify to be included. For gene therapy, you were mentioning, just to use the AV9 as an example, you know, it's readily available in the environment. It has no symptoms if you have that virus, I understand. My kids have eaten sand. They've been in daycare. You know, how probable is it that you have antibodies? Is that something that you can also, when you're working with your geneticist, say, I'm interested in these studies, is it possible, is it a standard test that you can even do at this time, or is it just part of the study?
So one of the challenges is we know so little in reality what the true exposure of AAV to people in this room. How many have actually had an AAV infection? And it makes, as Kevin alluded to, it makes important what AAV infection. There's probably now, I think Jim Wilson's come up with 100 or so plus known AAV. It's like the common cold. There's 100 or so rhinoviruses. If you get affected to one, it doesn't mean you're going to get immunity to the next one that comes along. And so, first of all, it's not a standard test. You can't go to your geneticist and say, I want to see what my antibody titer is to AAV2, and you can name them. So that's so it's not possible at this point. AAV9, I think, turns out to be relatively low seroconversion in the population. Do you know that number, Kevin, at all?
Well, we have unpublished data that Dr. Fu is putting together, but it's a relatively low number of patients. It's not it's really a minority, significantly a minority of patients who are exposed to it. And in part might be because even though your child eats sand or does other things, in many ways, some of the other engagements with the community are different. For some parents, the standard classrooms, they're not involved with the same way, and so on.
But I think, so that's something we can't control at the moment. But just be aware, we're really in the beginning of gene therapy in terms of we're using AAV. I can envision that in the future, we're going to have now what I call designer vectors. That is, we're going to, in the laboratory, modify the coat protein that uses to infect cells and can make vectors that are completely novel in terms of immunity to man. Okay. For example, the Sanfilippo direct brain injection trials in Europe for both A and B are using AV RH10. That RH stands for rhesus monkey. They came out of the rhesus monkey, and so none of us have had any conversion of that exposure to that particular AV vector, and so there's no limitation in those trials.
Okay.
Can I just add, I'm sorry, just one
Go
other
ahead.
thing to that. There are strategies that we can think of that will allow patients to be treated even if they carry those antibodies. They're not built into the first trials, but for example, Dr. Louis Chiquan at our institution has published it, Jerry Mendel and the group have published data looking in monkeys who carried antibodies to certain AAVs to doing a procedure called plasmapheresis, which is a clinical procedure that's done for certain antibody-mediated diseases. It's possible to do plasmapheresis in a monkey who's been environmentally exposed and to temporarily lower the antibody level and then treat the monkey and get reasonable expression of these reporter genes. So, you know, again, those are things that we don't build into the first trials of this because that's gonna complicate the issue about is it safe and does it work. But clearly, I think there's other exploratory ways to think of knocking down antibody responses and treating even if we only have one vector at a time a few years from now.
Okay.
We have to remind people that this is just really the beginning of the trials, and we want to find safety. We want to make sure we can give these, as Kevin alluded to, and that we don't see any acute effects, and then we can sort of figure out what the effectiveness is. But, you know, we clearly need to show the safety first, and I guess, you know, a lot of people already assume just because we start trial, they're going to be effective. I don't think we know that, or safe. We got to prove it's safety. You know, these are not like we know it's going to happen. There's so little exposure in reality.
Okay, got it. Thank you. The second question I have is, Dr. Flanigan, you showed a slide in the beginning of your talk about the type of mutation. I couldn't retain it. I couldn't get the message, so the type of mutation and...
How it might impact, so yeah, sure. Well, broadly speaking, there's two kinds of mutations that cause disease of enzymes. One is a mutation that truncates the production of the protein overall. And in general, if I have what Dr. Muenzer referred to as stop codon mutation for that example, where the translation of the protein is truncated partway through, that protein then is unstable and often degraded and never really goes out into the system. It's never really made in any numbers. It's undetectable with antibodies, for example, to make it. Another kind of mutation is a missense mutation, where there's a change at a single amino acid, but the protein is still made all the way from start to finish. It's just got a critical change at a critical point. And with some of the patients with enzyme disorders, that mutation, the protein is still made, but the mutation is at a site critical for the enzymatic activity. So you make a detectable protein. We can find a protein of the right size, but we can't find it making enzyme activity. So what I intended to say was those are two different situations for whether a patient with disease has ever seen a protein or not. One group has never been tolerized for that protein. The null mutation group is what I refer to it. That includes stop codon mutations or other mutations that shift the reading frame, that stop translation. So null mutation patients have never been tolerized for protein, whereas missense patients presumably have been. And we would predict, and again, it's a prediction, it's one we have to sort of follow up on in these first trials, we would predict that missense mutation patients are unlikely to make antibody responses directed at the gene we put in, whereas null mutation patients, those who've never seen the protein, are more likely to have an immune response to the actual protein created by the gene that we put in. So I just brought it up to say it's one of the challenges and it's one of the issues as you go forward in clinical trials. I fully expect some clinical trials will only specify enrollment of patients who have missense mutations, for example, for characterizing the safety. I can't say that for sure. It does enter into consideration, for example, as we look at safety signals from first patients, how we can expand it to other patients. Can we risk that enrollment of patients with null mutations?
I just want to follow up that, and Kevin can maybe comment on that. One of the challenges, if we take a nonsense patient who makes no protein, they're going to make antibodies. But what we don't know yet is how much that antibodies are going to have an impact on potentially gene therapy, where what we do is the DNA goes into the cell, that cell makes enzyme, and then we're going to correct that cell. We certainly rely on potentially a bystander effect to correct other cells, but it's not clear how much this antibody issue is going to be prevalent in terms of how much will that inhibit. We also know that if we impact some of the cells that make antibody, we in theory could potentially tolerize patients. And so there's still a lot for us to learn of how this is going to work. We know that our patients on IV ERT, a good percentage of those patients develop infusion reactions. And we can get through those infusion reactions by continuing to give the infusion and tolerize. It may be that in the future we'll have to do immune modification to really suppress these responses, and that's clearly coming along in a disorder called Pompe, a muscle disorder that's another lysosomal. For the severe Pompe patients, the treatment of choice is to immune modulate them or immune suppress them prior to start giving them ERT. And so that may have to happen for some of our disorders, and that may be what we have to do in the future for gene therapy as we see what works and doesn't work.
Hi. I have 3 questions. First one is ERT. I know that that's something that has to be done on a weekly basis, basically for the rest of their life, just to slow down the process. It's not a cure, it's a treatment. With the IT trial that you guys have going on right now, is that in the future supposed to be a cure, or is that going to be the same thing once a month for the rest of your life?
How about if you answer that question yourself? What do you think the answer to that question is?
I'm hoping it's a cure that would...
We're talking about treatments. We're talking about putting back and trying to prevent the ongoing storage. So it's not going to be sort of, again, it's going to be a treatment. Cures are really tough to come by. I'm a realist, as a lot of you know in the audience, but it's clearly a treatment. It's a step forward in the right direction. I mean, it's far better if we can prevent that brain disease from ever happening, but will it prevent all the problems? Probably not. Again, and I view these, yes, as in theory lifelong, but I really think there are going to be other therapies in the next 5 or 10 years that are going to dramatically reduce or even eliminate potentially IV ERT. We may think of someday as they did what? They gave weekly infusions of an enzyme produced in a factory and then got all sorts of reactions. We may think that is sort of an archaic thing. I hope that happens someday. It's clearly not there yet.
So to answer your question, intrathecal enzyme in the brain, it has a tissue half-life of about 7 days. So the enzyme is degraded inside the cell, and then it's really a question of how long it takes that glycosaminoglycan to reaccumulate to determine how often you really need to give it. And what we think is that glycosaminoglycans really accumulate fairly slowly in the brain, and it may be a month or 2 or 3 months before you need to dose that again, but it would have to be for life.
Okay, and I know you said that the IT trial is going to be ending soon. I know that it's in 3 parts of the states, North Carolina, Chicago, and California. When you say you're going to be closing down the trial, is that for all 3 places, or is that just for North Carolina?
So it's not closing the trial. We're going to stop new enrollment.
Okay.
The trial's going to continue long term. It's not like some of my study staff are here in the back, and they would shock to say we're stopping the trials, and they'd be out of a job. They have a job. So it's stopping enrollment. We reached our enrollment criteria, then it basically requires the trial to go 1 year, and then after a year we can start to see what we did. Did we do good things or not? Is there benefit? Because we're looking for in the intrathecal trial improvement. We're looking for basically registration in the U.S., which means the FDA approves it, and in theory that anybody can use it. In the clinical trial, we excluded patients with increase in intracranial pressure. We excluded patients with shunts, and potentially, once the drug is approved, as a physician, the FDA may say it's not approved for those patients, but I can still give that drug to a patient as a physician. So it's not stopping. It's continuing ongoing. Just like the initial patients in the first trial I talked about, there's patients now out more than 6 years, and they'll continue to receive, basically enzyme as part of a research protocol until either the company stops or the company gets approval.
And then this is my last question.
You can have more questions than this.
Okay. Our son was recently diagnosed, and one of the things that we've been coming across is some people are saying, get a port. it'll be great for him, it'll benefit him, and then some people are saying, don't get a port, it's the worst thing you could possibly do. We're going crazy and don't know what to
So
do.
what you're referring to is how long have you been doing IV enzyme infusions?
About 2 months now.
So basically, in the audience, what you're referring to is you put a central line or a portacath in to allow easier IV access. And it really is, if you can put an IV in comfortably without a lot of trauma to the individual and it's successful, then there's no reason to not do that. But if you have an issue where the child now is very difficult to get access to, you poke him multiple times, he's becoming behavioral, lots of challenges, then a port can be considered. Like anything else, a port has risk. You can get infections, there's occasional, you can have bad things happen with ports. And so you use a port if you need it, but if you don't need it, try to get without it. But there's no perfect answer.
But does that damage, because I was told every time they do an IV every week, that eventually damage the veins?
Well, your veins get damaged, but veins regrow in some ways. So it's not like, yes, if you keep putting an IV in, you'll basically lose that particular vein. But we have lots of different veins. We have the superficial ones we use, but there's a lot of veins. So that's really not an issue. Yes, we do damage veins when we put an IV in, but that's not a reason not to do that.
Thank you.
Given the risk of a port, which is not in itself insignificant. And maybe other families who have experience with ports can just comment for him.
Well, I do have a question about the port. So my daughter is getting IV Vimizim for Morchio, and I've heard the do the port, not do the port. We've chosen at this point to do the IV only in one arm, and that's 2 veins that she chooses between. And yes, there is a little bit of damage in those veins, but where they see the scar tissue, they try to go above it to try and preserve the vein the best possible. But my question is, a couple of years ago at World, I saw a presentation, and I can't remember the doctor, but he was a cardiologist talking about the long-term effects of having multiple port placements. And he was looking at the cardiac problems that were arising from that individual, the adult patient with MPS having cardiac problems. And now he was trying to address what was going on with the heart, but it had so many port placements prior to that there was issues preventing him from being able to treat the heart problem. And I don't have all the details, but do you see that as, if the MPS patient lives into adulthood a long life and they've had several port replacements because after time they do fail, would that be a complication should you have a heart problem down the road?
The general answer is no. I'm not aware of what you're referring to, but yes, one of the complications of having central lines, if they can get infected, and if that bacteria end up on the heart valve, called myocarditis, that's a significant issue. And so you can actually have patients who need a heart valve replacement from a complication of a central line. But I don't know if it's having multiple. One of the challenges, we have other patients I deal with, not MPS patients, who had multiple central lines, and there's some patients who have very little access anymore. It's sometimes very difficult to put a new central line in because we've effectively used up some of those vessels. The big vessels, they get clotted off. But I think the key is you have to weigh the risk versus the benefit, versus giving the enzyme, or not giving it. And then if port's the only way to go, then you have to, be aware of those risks. And if you think the enzyme is beneficial, and you may want to just comment, Vimizim is one of those products where we're not really treating the bone disease, but if you just want to comment how you think your daughter has done on enzyme replacement therapy, given that 10 years ago it was a lower sort of, we weren't sure whether Morchios would have any benefit or not from IV enzyme replacement therapy.
Yeah, so Annabelle is 10 now, but we got into the clinical trial when she was 5 years old. So we were one of the earliest treated for enzyme replacement therapy. And one thing that I saw happen was we were kind of going down a spiral of losing stamina, energy, not being able to, and just a lot of pain overall. We certainly have had surgical interventions too, so there's a lot of different pieces in play here. But once about 8 months into taking the ERT, Really did all of a sudden see this improvement. And I guess the story that I share all the time is when I would take her to the grocery store and I would have to carry her from the car, and this is at the age of 4 and 5, from the car to the grocery cart, put her in the grocery cart, and then push her around because she couldn't even make it that far. There was just too much pain. She was too tired. And then one day, 8 months into doing ERT, she says to me, "Mom, I think I'm going to walk it this time." She gets out of the car, she walks to where the grocery carts are, and I said, "Okay, you want me to put you in?" She said, "No, I'm going to walk. I'm going to do this." And went up and down the aisles with me and had that experience of like watching her endurance dramatically improved compared to 8 months earlier. So that for me was my aha moment of, okay, oh, it's not just me hoping to see improvement, but this is clearly a change. So for us, we definitely saw an improvement in her pain, her endurance. We have gotten to a point where I feel like we've kind of stabilized. So I don't see any more dramatic improvements, but she's been able to maintain, for the most part, where we are.
As you appreciate that, maintaining is really success, because normally this would be progressive, and that's sometimes what historically regulatory bodies had a hard time with. You know, they think of no change as no benefit, and no change for an MPS disorder is very important.
Hi, I have a question about the anti-inflammatory therapy. I've never heard of that until today, and I was not understanding exactly how it worked. And my second question is, they said it was adjunct therapy. Would that be a type of therapy you could use with somebody who maybe had a bone marrow transplant in the past or something of that sort, who is stable?
Yeah, so I can answer that, or I can start, you can. So, so what we found in animal models is that there's a significant amount of inflammation that may contribute to some of the symptomatology that we see. So some of this work was done by Lila Simonaro at Mount Sinai looking at TNF-alpha, and the glycosaminoglycans are similar in some ways to something that bacteria make called lipopolysaccharide, and that glycosaminoglycans can activate these inflammation receptors like toll-like receptors because they are like lipopolysaccharide, and it causes this inflammation. And specifically, some of the joint problems, in fact, some of the fibrosis we see, some of the brain involvement may even be due to inflammation. We don't really understand this or know how much. She is looking at an anti-inflammatory therapy that's called PPS, or pentosyl polysulfone, anyway. PPS, yeah, that works not just on TNF-alpha, but is kind of a global anti-inflammatory. There are some other TNF-alpha inhibitors that are out there. Remicade is one, and our colleague I mentioned, Linda Polgreen, excuse me, studying adalimumab, which is also known as Humira, to see if it can help with some of the symptoms. And so the idea would be it's not going to reduce glycosaminoglycans. It's not going to reduce lysosomal storage, although Dr. Simonaro's work with PPS shows it does, but there's some question about why. But at any rate, so it's not really going to affect lysosomal storage or the primary problem. It doesn't increase enzyme activity or anything like that. But what it might do is the inflammation that's causing some of the symptoms, if you can abate that, maybe you can use that alongside ERT. And yes, certainly a bone marrow transplant to see if you can improve the symptoms. So these are all, this is all, again, experimental. Nobody really knows. There is a PPS study that's being done. There's taking it orally or taking it injectably. Actually, there's different efficacy, and so orally, PPS is only available orally here in the US. It's not available as an injection here. So people are taking it orally. There are a number of clinicians who are prescribing it, and there are people who are taking it, and I don't know, it doesn't work as well as it does as an injection, but there's some data from her rodent studies that suggest that it does have an effect. Again, we don't know about in patients. And then Dr. Polgreen's adalimumab study, and I don't know of any others that are currently ongoing. But
regard to PPS. Yes, there is a planned study coming to the U.S. On injectable for PPS, Elmeron. You can actually research a bit online what Elmeron was originally. I think Dr. Dickson pointed out that was originally for interstitial cystitis. It's been on the market for quite a while, but you might want to read a bit about what PPS does, and look for upcoming trials in the next, hopefully the next year or so.
So is that a prescription medication or?
Yeah,
So you
yeah,
enhance-
Elmeron is a prescription medication, and yes, and the other as well.
The PPS is?
Yeah, PPS is Elmeron, yeah.
Okay, all right, thank you.
Like Sarah?
Dr. Dickson, can you comment on the Humira study versus the PPS and a little bit of that? Or-
I mean, I can try. The Humira study is only very new. So adalimumab is an injectable anti-TNF alpha. It's used for juvenile rheumatoid arthritis, so there's already experience using it in pediatric populations. As being an injectable, I don't know how to compare it with oral PPS or even with injectable PPS at this point, but it might actually have effects not only in, or theoretically it might have effects not only in reducing inflammation, but also there's a potential for it to reduce some of the antibody formation against enzyme replacement therapy. So Dr. Polgreen is looking at whether it might do that, and again, we don't know whether this will happen or not. So she studied 2 subjects so far, and she's hoping to get funding for a larger cohort, and so when that happens, there'll be an announcement and information about that study as well.
So my son was actually one of the subjects in the trial, and honestly, he just went off of it about 6 weeks ago, and we see a huge difference in his pain. And I think it took us a while to see the difference until he went off of it. And we were really impressed with, we'd do laps around our block. The physical therapist saw a reduction in his pain. We were stabilizing in his range of motion. There was just a lot of positive things from it. But at the same time, of course, it's an injection. And his thing was, I don't want to do it because it's every 2 weeks, but if it was in a pill form, he would love it. So
What form of MPS?
he has MPS 2.
Thank you.
It's Humira, and it's Linda Polgreen at UCLA very early, so it was the first, as you said, 2 patients, so we're part of that.
So I have been around long enough to remember when Elaprase was FDA approved, the N is 14. I remember meeting you on our first conference 3 days after it was FDA approved. And I also remember that there was a lot of backlash, not from physicians prescribing, but from insurance companies not approving Elaprase for the populations that were excluded. So my question with the IT trial, I know that there is obviously exclusionary criteria because Dan was not allowed in it for multiple exclusionary criteria. But will there be a follow-up trial for those excluded groups, and if so, what will that population include?
So it's a question that I can't answer directly since I'm not part of Shire. I work on their clinical trial, but they clearly are interested in doing clinical trials. If we see efficacy, if we see in the pivotal study that intrathecal enzyme monthly appears to be beneficial, then I think there will probably be trials with patients who have been shunted, or patients who have increased intracranial pressure. So there will be some other trials in sort of this expanded access. Once we have drug data in terms of if it's promising, then they may then take that and do some other trials. But I think it's really too early to say when and where those trials will be. But there most likely will be something.
Okay, because I personally already know that I'm going to have to fight to get a prescribing physician because I don't personally feel like our geneticist would be qualified to oversee that because of the shunt involvement. My neurosurgeon would have to be involved, and he is very resistant to the idea already. So just knowing that I'm going to have to fight a physician as well, am I going to have to fight insurance on top of it?
I think the first step is we got to show it's effective,
Yes.
and that then once that's then the case, then there may be clinical trials, and like the current clinical trials, as you heard, there are 3 sites in the U.S., and patients will have to go to those sites, like we have, just to show the safety issue. Because again, the more safety data we can accumulate and clinical benefit data, that's what helps get something approved.
Thank you.
So be patient, unfortunately. I know you've been patient.
We're bumping up against the hour, so I think we have time for one more question.
One more question. Okay, so for the, I'm a parent of a Sanfilippo type A kid, so interested in both ERT and gene therapy. What is an optimistical, and I caveat with that, best case scenario timeline for for the drug to be, or the treatment to be commercially available here in the United States? And second, would it be faster in other countries? Gene therapy, yeah.
Well, the first thing I should say is I don't speak here on behalf of Abeona, who clearly has commercialization plans internationally and so on. What I can say is, from my view in interactions with the FDA and from my view of experience in other diseases, rare diseases that have gone before the FDA, I believe if we show safety at both dose cohorts, and if we show efficacy signals based in comparison to the natural history data we've shown at 6 or 12 months in the patient population, I believe that it will be a rapid path to commercialization, to registration. That's my belief. Accelerated approval rules in the FDA don't require that you, what they require is that you do one study that shows a clear benefit, and not that you have study. It doesn't mean you get things approved without a clear benefit, marginal benefit. I mean, you have to show one good trial. That's one of the things. The other thing that's allowed under the rules for accelerated approval are clear intermediate endpoints that are agreed upon, what are called intermediate endpoints that everyone will agree to predict a beneficial outcome. If we have those biochemical measures that are sustained, or if we have clinical measures that are sustained at the time points we define of 6 or 12 months, and they're clearly distinct from the natural history, either of the individual patients or the population as a whole, I actually believe it's going to be a relatively rapid course to commercialization. I don't, but I want to emphasize that's based on what we've defined as outcomes at 6 or 12 months. Those are predefined outcomes. That's one of the reasons I am reluctant, we're reluctant to evaluate any efficacy at this point based on measurements that we have in hand, and on only 2 patients, that where we stand. So, but I do think that current rules for approval, if we get a clear signal for this, that there will be a relatively rapid path toward commercialization in the U.S. Will it be quicker elsewhere? I'm doubtful of it. I actually am quite doubtful. I think we're significantly ahead of efforts for this same agent. You may have heard the company announced this week that they have gained approval for clinical trial approval in Spain. I think that our results, our clinical trial design, and our... Oh, I'm sorry. I apologize about that. I tend to go... I don't have to start all the way again at the beginning of the response. Okay. I probably wouldn't say the same thing twice. I do think that our results and our data and our design and our safety parameters might, this is a prediction not from knowing what Abeona will do in Spain, but may allow some adaptation to the trial design to allow even more accelerated enrollment. That's potentially, that's a possibility. But I really don't think approval is somehow going to be quicker elsewhere than here. I think the path here is clear for accelerated approval, with either clear intermediate biochemical, pharmacodynamic biomarkers, or clear functional benefits as we've defined in the trial. Now, it might be that neither of those is achieved, in which case we're talking about 6 to 9 patients here in the U.S. It may be that it's sufficient as the trial is designed to show there's clear safety. We can enroll many more patients in a subsequent trial. It will allow us to enroll them more quickly. The company should have more product to allow us to enroll many more patients more quickly. Any subsequent trial will go much more rapidly than this first trial. That's not because the FDA is putting their foot down. It's because we as clinical trialists, or I as clinical trialist, I don't want to give this to 4 patients in a week apart and then find out later that a month later that there's toxicity to it. We really have to show it's safe. Once we've shown safety, we can do a second trial that's designed very differently to enroll patients more rapidly and answer efficacy questions differently. Long answer, sorry about that.
Okay. We want to thank our experts today for presenting such wonderful information for all of us, not only for your work today, but for your work every day in your labs that actually help change our tomorrows, and we want to thank each of you for that work.